Hello, I'm going to present 2-year fixation results from ProgStar and how the changes correlate with exam features, baseline measurements, and the genotype. There are no relevant financial disclosures. Let's first go over the rationale for doing this research. You know that several treatment approaches for Stargardt disease, such as stem cell therapy, gene therapy, and pharmacotherapy, are currently in clinical trials. In order to demonstrate their efficacy, it is possible to show structural progression on fundus autofluorescence or OCT imaging. However, in order to obtain market approval, these parameters should be associated with functional changes. Visual acuity has been used over decades in clinical trials for age-related macular degeneration and diabetic retinopathy, but its usefulness in Stargardt disease is limited due to the slow and variable progression, and eyes with severe visual impairment in Stargardt disease actually show a statistically significant improvement in visual acuity over time. Changes in fixation behavior may explain some of these changes. The purpose of what I'm presenting today is the following. We want to report the yearly natural progression of Stargardt disease using fixation parameters to investigate associations with demographic features, exam findings, and genetic features, and we want to identify situations where fixation parameters provide useful additional information beyond visual acuity or microperimetry testing. The ProgStar study aims to develop new endpoints for clinical trials for Stargardt disease. All patients in the study have a molecular diagnosis of Stargardt disease type 1 with at least 2 mutations in ABCA4 or 1 mutation in ABCA4 plus a characteristic phenotype of Stargardt disease. The central reading center is the Dirk. The Dana Center at Johns Hopkins is the data coordinating center, and Hendrik Scholl is the study chair. For the study design, ProgStar has 5 study visits, and they are all 6 months apart from each other. Fixation testing was performed at each visit using the NIDIC MP1 microperimeter, and we have 24 months of follow-up. There are 259 participants and 489 eyes in ProgStar. Not every patient underwent microperimetry testing, and not all eyes were gradable. In the end, we had 239 patients and 459 eyes. How did we perform fixation testing? The patients underwent microperimetry testing at each study visit. All testing was performed monocularly with the contralateral eye patched. Before the sensitivity test, the patient underwent a fixation task of about 30 seconds, where they had to fixate as steadily as possible on the center of a single red cross on a white background. This is called static fixation testing. The alternative would be to conduct dynamic fixation testing while the patient is taking the sensitivity test. However, this is affected both by the long test duration and the fact that patients focus their attention on not missing any presented light stimuli. Here you can see how this eye attempts to look at this red cross. Every 40 milliseconds, or 25 times per second, the location of the retina used to fixate is recorded, resulting in this cloud of blue fixation events. How do we describe how stable fixation is? The answer is that the closer the fixation points are to one another, the more stable fixation is. There are multiple ways of doing this. Some articles just categorize as stable or unstable with an arbitrary cutoff. Others describe how many % of fixation events are within 2 or 4 degrees of the center of gravity of all fixation points. The best way to quantify fixation is using the BCEA, the bivariate contour ellipse area, which is the smallest possible ellipse that encompasses one standard deviation of all fixation events. This is a continuous parameter, and it correlates well with reading abilities. There's no arbitrary categorization, and it recognizes the elliptical distribution of the fixation events. There's a complicated formula underlying it. You only need to know that both the standard deviation of the distribution of points in the horizontal and vertical direction are part of it. The location of fixation was also quantified using a continuous parameter. The distance of the eccentricity of the center of gravity of all fixation events was measured in degrees from the anatomical fovea. We followed fixation for all 239 patients. Here are the demographics with a mean age of 34 years old. The mean visual acuity at baseline was 46 ETDRS letters, which is about 2125 Snellen equivalent. We also have the visual acuity categories based on the WHO criteria. Just note that all categories are represented. The average BCEA for one standard deviation was about 5 degrees square. Compare this to the 0.1 to 0.5 degrees square in normal eyes. As expected, fixation stability is more unstable in eyes with Stargardt disease. You can imagine that the distribution of the BCEA is very skewed towards high values, as the area of the ellipse abruptly increases in cases of multiple fixation loci. We found that the logarithm of the BCEA has a more normal distribution. We felt that it better represents our data, and we decided to report the results primarily using the logarithm of the BCEA. Also note, on average, the gravitational center of the fixation points was 6.5 degrees away from the fovea. We calculated the average BCEA for all 5 study visits, and we color-coded them in the graph by baseline fixation stability. You can see that for the overall cohort, we found a small yearly estimated increase in the log BCEA of 0.124 log degrees square per year. The progression rate during the first versus second year was not different. We analyzed the yearly progression rate based on the fixation stability at baseline. Again, 3 groups with the group cutoffs at the 33rd and 67th percentile. You can see how the 1/3 of eyes that were most unstable with a high log BCEA, there was a statistically significant reduction over time in the log BCEA, meaning that these eyes on average developed more stable fixation. For the other 2/3, fixation became more unstable over time. We did a similar analysis for the eccentricity of the preferred retinal locus, but there was not a statistically significant change over time. And its average eccentricity remained very stable in all 3 groups categorized by baseline eccentricity. We previously categorized all patients in ProgStar into one of 3 genotype groups based on the number of severe variant mutations, for example stop, frameshift, and intronic variants that result in significant splice site alterations, and the number of missense or in-frame insertions or deletions. The progression of fixation stability in the 3 groups was not statistically significantly different. We also looked for associations with various other baseline characteristics. You see age, gender, visual acuity, fundus features, but no associations were found except for the absence or presence of flex outside of the vascular arcades. And here's some cases that show the usefulness of fixation parameters in Stargardt disease. This is a 55-year-old male. He has 3 mutations in ABCA4. He was diagnosed 15 years before enrollment into the study. Microperimetry testing of the 4 central or 4 foveal test locations suggests that there is an absolute scotoma in the center, but the visual acuity tests between 77 and 87 ETDRS letters on all 5 study visits. This corresponds to 2020 to 2030 on the Snellen chart. The visual acuity is indicated in the bottom right. Here is the month 12 visit enlarged as an example. You can see that the eye was unable to detect the brightest light stimuli in the central 4 test locations. However, there seems to be an area between the test points that is used for fixation, and the magnitude of the BCEA here is that of a healthy eye. This BCEA was maintained over all 5 study visits. It is indicated as the BCEA for one standard deviation in the bottom left. This is the right eye of a 28-year-old female who had been diagnosed with Stargardt disease 11 years before the baseline visit. She has 3 mutations in ABCA4. You can appreciate a dense patch of atrophy of the retinal pigment epithelium in the central macula, and she uses a PRL superior to where you would expect the fovea. Visual acuity is reduced to 34 to 38 ETDRS letters, which corresponds to about 2200, and fixation is more unstable than in the previous example. Interestingly, she maintains the same PRL throughout all 5 study visits. This example shows the opposite. A 35-year-old female, diagnosed 6 years prior. She has a large area of atrophy extending over a large portion of the macula. Visual acuity is reduced throughout all 5 study visits. She uses a PRL directly adjacent to the area of RPE atrophy for the first 6 months of follow-up. At the month 12 visit, the PRL shifts to the peripapillary area that is spared from RPE atrophy, and the PRL stays there. In summary, this is the largest study following fixation parameters in Stargardt disease type 1 over a period of 2 years. We found small but non-monotonical changes in fixation stability over time, but no changes in the eccentricity of fixation. Due to the variability in measurements and this non-monotonical progression, at this point we believe that fixation parameters appear unlikely to be sensitive outcome measures for clinical trials in Stargardt disease. However, fixation may provide very valuable ancillary information on an eye's visual function. We believe that further investigation of the fixation locus with structural testing is valuable, especially in areas of residual functional retina surrounded by non-functional tissue. This may provide valuable information for both clinical trials and for counseling patients. Thank you very much for your attention.